Welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we bring this podcast to you every Wednesday as a veterinarian, as a technician, as a dentistry team to help you be even better at veterinary dentistry in your practice. We're sponsored and partnered today with the Veterinary Dental Practitioner Program. If you're interested in being among the best anywhere in general practice as a team in veterinary dentistry, I invite you to request an invitation. Let's go to ivdi.org/INV, like invitation, first three letters INV. So IVDI, International Veterinary Dentistry Institute, ivdi.org/INV, and we'll get you the information that you need.
All righty, our next question. Annabelle, by keeping a small dental team made up of 1 to 2 doctors and techs specifically interested in dentistry, wouldn't that be somewhat what is contributing to why dentistry is behind compared to other areas in vet med? Nope, they're behind because there is absolutely no information given at the university level. These veterinarians especially, they get less dentistry training than technicians do, I think. So everybody's coming out working in the dark. And so we want to make sure that we're getting our staff very specialized with good CE and then practicing that on a pretty regular basis. Everyone in the practice would not be as efficient and educated in that area. I'm also interested in how you mentioned the palpebral reflex is not an indication of a patient being too light. Does this also depend on eye positioning? It doesn't. I'm not sure what eye positioning means, but the palpebral is my number one parameter, along with all of my numbers on my monitor, what plane that patient is at. And there's different, degrees of palpebral. Is it very profound? I mean, is this dog like really blinking as soon as you touch it? That's a little light. And so we want to get that dog at a little deeper plane, but we still want that palpebral to be present. Even if it's subtle, it's still there. We don't want it to ever go, and we don't want the eyes to be, relaxed to the point where they're just staying open. That usually means they're too deep. So that palpebral, really get used to taking a look at that and seeing what level and how profound or subtle it is to kind of help you gauge that. But our dental teams, again, getting back to that, we really want to kind of immerse them in dentistry, not only with CE, but in that dental suite and doing dental patients over and over and over again as often as possible so that they get just really good. It just stands to reason. The more consistent you are, the more you do it, the quicker you're going to get. And so keeping that dental team small allows those folks to be immersed in dentistry. And hopefully at some point we will get more comprehensive dentistry courses offered at the collegiate level so that when folks are coming out of school and graduating, they're not completely in the dark and having to make stuff up as they go along, which has often been kind of the route for veterinary dentistry, unfortunately. My first question, how do you explain to owners the estimates if they want an estimate for the entire procedure, not the 2-part? Do you ever stage dental procedures after taking full mouth rads and having multiple issues going on? And are the clients okay with this? Good question. Whenever I talk to patients or clients that are scheduling appointments, and I typically have scheduled for both locations. I do have an assistant now. And so we give the same kind of verbiage that we start out with what's called our oral diagnostics at X amount. That's going to cover the consult with Dr. Beckman, the initial anesthesia, IV fluids and monitoring, full mouth x-rays, and a cleaning. And unfortunately, we aren't able to diagnose until we see those dental x-rays. And dental x-rays have to be taken with them under anesthesia. Now, if I have a patient that is a 12-year-old Yorkie with no history of dentistry, I know we're going to go over that. And so I will give that owner a range of, we could be looking at X amount to X amount, maybe a mid-range or a little bit higher, what our standard, multiple extraction perio patients are. And so if you have an idea of what that is, certainly you can kind of give them a heads up if they are really pinning you down. And we want to kind of vet those folks. If they're not financially ready, if they don't have, anything beyond that diagnostics, we're going to wait. We're going to let them talk about care credit, let them kind of save up for the procedure, and then we're going to get that patient in. So that kind of helps, vet those folks before scheduling an appointment so that we can at least have somewhat of a budget, even if it's not for the whole thing. At least if we have some amount that we can work with and do part of the work, where we can at least do the worst part and hopefully make that patient comfortable. And this happens sometimes when I call folks when they're on the table under anesthesia. I give them the full estimate, and I always have a plan B. What kind of a budget are you working with today? Great. We can do some of this work, the most, nastiest stuff, the stuff that's, most infected, probably causing the most amount of pain. Let's get that out of there. We'll get everything cleaned up. He's still going to feel so much better. We want to make sure that we're letting them know that we're still going to have a positive effect, even though they can't do the entire treatment plan. And then we give them a 3-month window to come back to complete the treatment plan. And we've had to do that even in our practice, which is referral only. But some folks just, can't afford those big ticket items all at one time. But at least give yourself, estimate them, give them a budget to, I don't see it being less than this, but it could certainly go over. We won't know until we see the x-rays. So that way you have at least some money to work with beyond that oral diagnostics to be able to do something to help that patient. All right. Kelly writes, do you use the same anesthetic protocol for all breeds of dogs, besides adding the Torb for working police dogs? The Torb is only for dogs that are just off the wall, that are unhandleable or extremely nervous and may lash out. The Torb is used on a very small number of patients. The hydromedaz, yes, that's used on pretty much every single breed. That protocol is safe for cardiac patients. In fact, that's what a lot of the cardiologists recommend, is a narcotic, benzodiazepine, induced with propofol. That's pretty much their recommendation. Now, for our brachycephalics, sometimes we'll add a little glycopyrrolate to open up those bronchi, pre-oxygenate with a little O2 if they are not, thrashing and fighting and we're stressing them out more doing that. But if they'll allow it, we do oxygenate before we induce with propofol. So we get them up on the table, get a big mask, just put some O2 on them, and then induce. So those brachycephalics, there are special kind of protocols for those particular breeds. But as far as the pre-medication, we pretty much use that across the board. Very successful with that. Amy writes, is there a reason you don't give your medication IM? And again, just because that hurts. And then do you give Serenia IV before induction? We give Serenia as close to when we do the pre-medication as possible. So if they're not able to be handled, we give that pre-med, let them relax, and then we can usually place the catheter, and then we're going to put that Serenia on board as soon as we can. We like to have that, as close to the pre-med as we can, so it has some effect. And we don't typically dilute it. And that's one medication that we don't give any other route besides IV because it can be painful. So we try and avoid that as much as possible. Do you ever need to use home sedatives for anxious patients prior to coming to the clinic, such as trazodone or gabapentin? Do you take pre, intra-op, or post-op photos for your records or client education? Gidget, excellent questions, both of those, and I'm glad you brought all of that up. We absolutely do work with our primary referring veterinarians, and if we have a patient that is known to have high anxiety, we absolutely want them coming in, gabapentin, trazodone, whatever they prescribe, we are okay with. It works very well with our anesthetic protocols. We don't have any contraindications with any of those. And as much as we can relieve that anxiety for both the patient and the owner, we are absolutely all about that. So if I've got a patient that comes in and the owner says, this dog is going to flip out if you take her away from me and put her in a cage, then we're not going to take her away. She's going to stay with that owner until we induce. And I'm going to find out that information at the time that they schedule, that if you could hang out for a little bit in the morning and just let her be with you until we get her to go right on the table. She's not going to go in a cage. She's not going to hang out and be subjected to those triggers that is going to cause this patient so much anxiety. I have people hang out in their car, walk around outside, just hang out in an exam room if you have the space. But I'm going to try and relieve as much of that anxiety as I can. And sometimes it's more on the owner than the patient. But if the owner is high anxiety as well and they need to stay with that patient, that's what we're going to do. So we kind of think outside the box and really cater to those folks so that we can make it as pleasant as possible so that they come back. We really have to exceed those expectations. That's so important with those dental patients that we need them to come back. Now, we do take a lot of photos, but we take not of the before and after cleaning, because remember, it's not about the cleaning. It's about pathology. So if there is gross pathology, we are going to take pictures of that. And then if there's any pathology on radiographs, those are going to go in the dental report as well. So it's all about pathology. And so we are kind of showcasing that. This is what we found. This is what we did to treat it. And this is what we want to do to avoid this happening in the future. So especially with periodontal changes, bone loss, all of that. So it's all about explaining and photographing pathology and then putting that in their dental report. Way more important than the before and after cleaning, and it puts the emphasis on the cleaning, and that's not what dentistry is about. It's about assessment, treatment, and prevention, and that's a huge paradigm shift because this is what's gotten us into the boat that we're in now with teeth cleanings, and now we have these 8, 10, 12-year-old smaller breed dogs that all we're doing is extractions, rather than if we would have assessed them at 12 to 18 months of age and then treated them throughout their life, most of these patients would still have the majority of their teeth. So we want to kind of make that shift to that type of philosophy and culture and proactive dentistry rather than reactive dentistry. And teeth cleaning, if there's disease present and we don't find it and treat it, teeth cleaning has absolutely no benefit. That is huge. So keep that in mind as well.
I hope you enjoyed that episode. If you'd like more information about the Veterinary Dental Practitioners Program, please submit to request an invitation. at ivdi.org/INV.